Hello, and welcome to today's webcast titled Clostridium difficile. It's complicated. My name is Sarah Lewis with Meridian Bioscience, and I will be your moderator for today's event. During the presentation, you will be able to submit questions. Please click the green Q&A icon in the lower left-hand corner of your screen. Type your question in the open area and click Submit. Questions will be answered at the end of the presentation in the order that they are received. A few housekeeping notes that we would like to mention. If you would like to view the presentation in a full screen view, click the full screen button in the lower right-hand corner of your screen. Press the escape key on your keyboard to return to the original view. For best results in viewing this presentation, we suggest you turn off pop-up blockers and disable instant messaging programs to improve computer performance. If you are experiencing any difficulty with the audio portion of this webcast, we recommend using a wired high-speed internet connection, as wireless connections can be unpredictable. And finally, should you need any technical assistance, as a best practice, we suggest you first refresh your browser. If that does not resolve the issue, please click the support option in the upper right-hand corner of your screen for online troubleshooting. It is now my pleasure to introduce today's program. This presentation will include discussions around the current controversies that surround laboratory testing for C. difficile, improving therapies, the future, and more. I would now like to introduce today's speaker, Dr. Margie Morgan, Professor of Pathology and Laboratory Medicine at Cedars-Sinai Medical Center in Los Angeles, California. Her clinical and research interests include areas of microbiology and antimicrobial stewardship, and she has written a number of peer-reviewed publications. Her affiliations within Cedars-Sinai system include Infection Control Program and Laboratory and Institution Biosafety. At this time, it is my distinct pleasure to turn today's program over to our presenter, Dr. Morgan.
Well, good morning, everyone. I think you're probably listening to this webinar because you're most, like me, we're trying to make decisions on the best way to do laboratory testing for C. difficile. But as my title says, it's complicated. It does not just involve microbiology, it's really become a hospital issue. And it's become a collaborative effort with microbiology, stewardship efforts with pharmacy, and infection control. I'm no expert. I'm here just like you, and some of you may be experts, but I'm coming to you as someone who works in the laboratory, who has to make some of the decisions on new laboratory testing, and trying to understand all that's going on with Clostridium difficile. But it's complicated. So let's get started with my story for the day. I'm basically going to tell you my story of Clostridium difficile. So let's start with the history. It's always good to see where all of this started. Clostridium difficile was first isolated from the stool of a healthy infant by Hall and O'Toole in 1935. It was named difficile because it was difficult to culture. I like that name because oftentimes the names to organisms have nothing to do with anything, but this one I could agree with. Clostridium difficile is difficult to culture. It was also interesting at that time it was not associated with a disease in the healthy infant. Antibiotic-associated enterocolitis was generally attributed to Staph aureus in the first 25 years of the antibiotic era, until in 1974, a researcher named Tedesco reported the results of around 200 patients that had been given clindamycin who had undergone endoscopy after developing diarrhea. 21% of them had diarrhea. A good percentage, 10%, had pseudomembranous colitis. But lo and behold, none of them had Staph aureus in their cultures. So this really brought into question all of the previous thoughts that Staph aureus was the cause of this disease. Researchers started looking for another cause, but it was clear that the incidence increased with the use of antibiotics. No one questioned that. The search continued for the cause, and it led to much research and many publications. And one such publication described an agent of major interest. Lo and behold, this was from friends of mine here in West Los Angeles, VA, Lance George and Sid Feingold and his great group of anaerobic bacteriologists. As the name says, it's the antibiotic-associated pseudomembranous colitis due to toxin-producing Clostridium. This was published in 1978. They saw that it was an anaerobic gram-positive, spore-forming bacilli capable of forming cytotoxins that they believed to be the agent of this horrible colitis. 25 to 30% of the antibiotic-associated diarrhea and greater than 95% of the cases of pseudomembranous colitis were attributed to this new Clostridium species. They thought it was the major cause, if not the sole cause, of antimicrobial-associated colitis. The other thing that was very a breakthrough and helpful to us in the laboratory was they noted that the cytotoxins could be neutralized by Clostridium sordelii antisera. So this was demonstrating that cell culture cytotoxicity assays were useful for the laboratory testing of C. difficile infection. I don't know if that was a good thing or a bad thing, to tell you the truth. I don't know how many of you suffered through cell culture cytotoxicity assays, but it at least gave us a good and new tool to start looking for C. difficile. The knowledge really evolved from 1978 to 1990 after this original discovery of what they thought was the organism. They started defining the clinical features of infection. They saw that 90 to 95% of individuals with C. difficile infection had watery diarrhea. A goodly percentage had some blood in the stool as well. There's also usually associated an elevated white blood cell count, and oftentimes the patient might have fever. Now, these were defining the clinical features of infection of Clostridium difficile, but you could take a look at that and say, that could be a lot of other diseases as well. And hence, that's one of the problems that started in 1978 and continues through today, that the clinical features are not spot on for C. difficile. It is a lot of symptoms could be many other entities as well. The other thing that happened from 78 to 1990 is we established some methods of laboratory diagnosis. I actually worked in a laboratory during this time and did the cell culture cytotoxicity assays. We also tried our hand at enterotoxigenic stool cultures. There was a latex particle agglutination test that was also somewhat popular. But the problem with these laboratory methods is they were slow, sometimes taking up to 72 hours, maybe even longer, and they were somewhat insensitive methods. So the problem was physicians were not very happy with us during this time because we were slow in producing results for them, and this could have possibly led to some questionable treatment choices, particularly while they were waiting for us to come back with laboratory diagnosis. Also during this time, principles of infection control were being investigated. There were reports of occasional nosocomial outbreaks, and lo and behold, there were even reports of patients who had not had any antimicrobial therapy acquiring C. difficile. And also, there were reports at the time of some very, very serious cases leading to death. Treatment options were also being explored for C. difficile infection during this time period. In 1981, vancomycin was approved by the FDA for use in CDI, closely followed in 1982 with the use of metronidazole. You can certainly see nothing much has changed with the treatment. These are still two of the most common drugs used in the treatment of C. difficile today. They also did a lot of studies of the normal host protection from C. difficile. They learned that once we're exposed to the organism, we mount a protective humoral immune response, forming both an IgM and IgG response to primarily toxin A. Also, it was found that if you had a healthy bacterial flora, it can help prevent colonization and overgrowth. I've included a little table at the bottom or chart showing how the disease progresses through the gut in the human. If you start on the left-hand side, you can see we ingest, after having antimicrobial treatment, a dormant spore. That will then go into the small intestine from the stomach, and you will get a germination of the spore. As it moves on to the right into the large intestine, it becomes a vegetative cell capable of producing toxin. At the same time, some of those highly toxin-producing cells will go into a cycle where it produces spores. That spore can then be passed in the stool and passed out to the environment, and through fecal-oral transmission, start the whole process all over again. The use of commercially available enzyme immunoassays came about in the early 1990s, and this was one of the first of many papers that were talking about how useful this type of EIA could be to the laboratory. This was a paper that talked about a commercially available enzyme immunoassay for the detection of Clostridium difficile toxin A. And this was the premier toxin A enzyme immunoassay that was originally produced by Meridian Diagnostics. This test was compared with the tissue culture cytotoxicity assays that we were using in the laboratory at the time, also the intratoxigenic cultures and latex agglutination test for the laboratory diagnosis of C. difficile disease. When they evaluated for detection of C. difficile disease using clinical specimens, they found that the EIA was the most sensitive of those methods studied, and that tissue culture cytotoxicity was the most specific test. The latex agglutination test was not as accurate as the other tests mainly to its poor sensitivity. So the EIA became a very rapid, easy-to-use alternative to tissue culture cytotoxicity assay for the detection of C. difficile associated disease. This was a very happy day in my laboratory. We had suffered through the many expanding numbers of specimens of cell culture cytotoxicity, and now we had a much easier way to diagnose C. difficile. One of the first publications about the use of was, as I said, in 1992 and 1993, and it moved us away from cell culture assays. EIA then became the most used test for the diagnosis of C. difficile disease. It was very useful because we could do batch testing as the specimen numbers started to increase. Also, the doctors were so happy with us because finally we were doing something that made some sense, and we were producing results within a time period in which they found useful. We were able to do our enzyme immunoassays in a batch mode daily, have results in 3 hours rather than the 72 hours prior. Tests have also been improved over time to, of course, both detect cytotoxin A as well as B. But as time moved on, I don't know about in your institution, but at Cedars, MDs started thinking like in the 1990s and early 2000s, they thought possibly we were missing some of the C. difficile infections by the use of EIA. And MDs got really they were really thinking hard on this, and they decided if you ordered 3 a day instead of 1 a day, maybe they could improve the sensitivity of the test. I don't know about in your laboratory, but all of a sudden we just saw our numbers just start increasing dramatically for C. difficile testing. During this time period, we averaged 2.7 tests per patient that were usually sent to us over 2 to 3 days. Of course, at that time, we were testing all the patient stools received in the laboratory. There was no thought about whether it was really that soft or liquid or how hard the stool might be. Of course, the physician knew what was correct, and any stool that was sent to us, we would test. But time marched on, and C. difficile marched on. C. difficile had become a leading cause of hospital-acquired illness. The cost has exceeded $1 billion annually in the United States. Data from CDC determined the rate of the discharge diagnosis of C. difficile infection had increased from 31 cases per 100,000 persons per year in 1996 to doubling amounts in 2003. There was an estimated 500,000 cases per year that occurred in the U.S., and the recent increase in the morbidity of C. difficile infection by as much as 25% per year, as well as a 20-fold increase in mortality. It was estimated that 15,000 to 20,000 patients died annually from C. difficile in the United States. Also in this time period, particularly from 2000 to 2010, we saw the rates and particularly the severity of C. difficile infections really increased dramatically. And most experts in the field related this to the increased prevalence of the NAP1 strain, which caused more severe disease with severe outcome and possibly death. I'm sure many and most of you, if not all of you, are familiar with the NAP1 strain, that it's characterized by higher than usual toxin A and B production. It's also a presence of a third toxin, a binary toxin. And one of the most interesting features as far as hospital antimicrobial stewardship goes is it had a high level resistance to fluoroquinolone antibiotics, such as ciprofloxacin and levoflox. And of course, during this time period was the heyday of quinolones. Also, there was a single base deletion at the nucleotide position 117 of the TCDC gene, a repressor of toxin A and B production that led to the increased levels of the toxins produced. During this time, there were numerous papers being produced to show how the NAP1 strain was really taking charge in the United States and across Europe and making our detection of C. difficile just that much more important and that much more problematic. During this time, when all of this action was happening, we became strong collaborators with infection control. And I'm not joking at all saying that they are guardians of the kingdom. It really became the responsibility of infection control to work with us in trying to take care of the hospital environment. During this time, C. difficile became one of the leading causes of hospital-acquired infection. A lot of recommendations came out at that time for C. difficile patients that we detected by our laboratory methods how we should isolate them and take care of their rooms. Of course, they were supposed to be put in an isolated single room that had a bathroom. They were put under contact precautions. All of a sudden, bleach became very, very important. Prior to that, we were not necessarily using bleach to clean rooms, particularly terminal clean of rooms, but it became very, very popular. Of course, this was your most effective way to kill the spore of C. difficile for the next unsuspecting patient coming into that room. We had to start all sorts of policies to adequately clean shared equipment. We of course, did not want to any longer use any type of rectal thermometers. Everything should be disposable. We started moving towards soap and water for hand hygiene. There's good evidence that Purell-type alcohol products do not kill the spores as efficiently as hand washing. So we, of course, tried to encourage all of our nursing personnel and physicians, don't just use Purell. Please wash your hands once in a while. And then antimicrobial stewardship programs became very, very important. Even before the government moved in and said that we had to do this, those in the know moved into trying to stop the usage of quinolones in the hospital environment because we knew we were just feeding the C. difficile problem by the high use of the quinolones. Because, of course, as I said, they selected for the NAP1 strains. What about those asymptomatic patients entering the hospital with C. difficile, the so-called carrier? Well, we never had to worry about that back in the 70s. We only worried about the patients that were in the hospital. But now, all of a sudden, let's jump to the present. Now we're being invaded from within with our patients that have ongoing C. difficile disease, and now we're being invaded from the outside with the silent carrier. There's evidence that they can contaminate the environment and healthcare workers' hands with possible transmission to other patients. So our study objective was detect and isolate C. difficile asymptomatic carriers at the time of hospital admission and observe the incidence of healthcare-associated C. difficile infection. So this was a study that for 1.5 years, admission screening by doing rectal swabs by PCR. Patients positive were then put into isolation upon admission and considered dangerous. 4.8% of those silent people, 4.8% of those people that they screened were the silent carriers bringing that organism into their institution. So what's the relevance? Significant decrease in hospital-acquired C. difficile infection, and the study estimated to have prevented 63% of expected cases. So 38 patients developed C. diff during their study period compared to 416 patients during the control period. So they really found that if we controlled and knew who was carrying and who were those silent people with C. difficile, we could make a difference. I might just say one thing, though, about those programs, and we've looked at them ourselves. They're expensive programs, and they can be time-consuming surveillance programs, but they have been proven in the literature to be effective. The other thing we're doing now, we're looking closely at the patient. We have careful selection of patients as needed before ordering C. difficile testing. This is nothing new, but you know, we haven't done a very good job since the 1980s really carefully selecting who should have C. diff. A lot of times it's just anybody with diarrhea, and sure enough, few of the studies that have investigated this issue have found that 36 to 50% of hospitalized patients tested for C. diff don't even have clinically significant diarrhea. 20 to 40% or so of them were on laxatives. Can you believe that? We're actually doing C. difficile testing on patients that have diarrhea because they were given a laxative. So, we need to improve patient selection for testing by only testing patients with clinically significant diarrhea, as well as stopping laxative use before testing. This should improve the positive predictive value of our assays. Problem: a lot of patients have antibiotics or chemo in the last 60 days of a hospitalization. So sometimes nosocomial diarrhea following recent antibiotic therapy or chemo can have symptoms like that of C. diff, but they might not be due to C. difficile. So once again, it's complicated. The patients are complicated, and we cannot always just absolutely select patients that for sure have C. difficile. We fixated on the perfect stool specimen. I have become a poo expert, I know. We looked at the algorithms following Shea and IDSA 2010 guidelines. We got into what is a soft or liquid stool. We do not want to test formed stools unless from a paralytic ileus, and at times we might have to even accept a swabbed specimen. They need to be in a clean container, refrigerate to prevent toxin deterioration. We want to discourage repeat testing during the same episode of diarrhea. We have to develop sometimes hard stops. That's what we had to do to prevent repeat testing within 7 days unless there is a discussion with me with a physician. If not, we were having testing just continuously on C. difficile patients. Testing for cure, of course, is not recommended. Molecular tests positive for 2 to 3 weeks following an episode of C. difficile diarrhea. So these tests were never meant to be tests of cure. Even toxin tests and toxins can continue to be shed for an extended period of time. So whatever assay that you're using, our tests are meant to detect the disease of C. difficile. It is not meant to detect cure of the infection. Cure is if there is no longer diarrhea, not if we have a negative test. Also, we know that there's a high colonization rate in children, so we do not want to routinely test infants less than or equal to 3 years of age. Yes, I have, as I said, become an expert in stool. I can't tell you how often I am looking at stool specimens to make sure that we're properly rejecting and properly testing specimens for C. difficile. Most of you are probably familiar with the Bristol stool chart. This is a chart that a lot of the nursing personnel use because they're supposed to only send diarrheal stools for C. difficile. In our hospital, they're only supposed to send the type 6 or 7s. This would be related if you use the Bristol stool forms for tots. That would be related somewhat to little things like this and gravy and such. So you can put it into food terms if you really want to, but I don't like doing that. But Bristol stool chart is what we're supposed to use with a 6 or 7. You can use visual examination, but one of the things that you have to be careful with is you need to make sure that the stool is at room temperature. If you're using stool that's just come out of the refrigerator, a lot of the stools can kind of look formed. So at room temperature is the best time to judge. This is one of the stools we received one time for C. difficile testing. It's not a joke. And sometimes you have to understand physicians may not actually know if the patient has diarrhea. I don't believe most physicians actually look at the patient's stool, and so they may just be taking words from the patient that they have diarrhea. So really, we do have to be the keepers of the gate and the keepers of the stool viscosity. This, I have to admit, has been one of the most challenging things for us at Cedars. I've had more arguments with physicians over whether the patient's stool was really formed or not than I have about virtually any other thing going on with C. diff. What I have actually done sometimes is send pictures to the physician just to convince them of the stool viscosity. The other thing a lot of people are doing now is called the stick test. And this is where you can just put a small type of wooden stick into the stool and see if it stands upright. If the stool remains standing upright, we say that the stool is formed. If the stick falls to the left or right and is not able to stand up straight in the stool, we say that is not formed. I think what I'm getting at is stool viscosity can be challenging and it can be very subjective. So you have to have some criteria for rejection which is standardized and consistent, or you're going to get into problems with your physicians and nursing personnel about what we actually call formed or not formed. Sorry to go off on this for so long, but you can understand from this what a big issue this has actually been for us. Okay, moving on to the laboratory tests. We have more knowledge, but it is complicated knowledge. We have a lot of tests possible for testing, but we have to choose what's best for our particular situation. Not every laboratory or hospital will find the same set of tests or the same individual tests will necessarily be the same for every hospital. We all have to look at our own situations and make the best decisions. And yes, this can have your head spinning somewhat about what to do. And I will stress, it does not have to be the microbiology laboratory alone, or should it necessarily be microbiology alone. We have worked very closely with pharmacy and infection control and in our infectious disease staff to try to develop the best testing methods at Cedars. So the introduction of molecular testing came about in 2009. And since then, about 44% of acute care hospitals have adopted molecular testing. It was supposedly replacing the insensitive and nonspecific immunoassay test for C. difficile. We will revisit that statement. This change in practice from EIAs for toxin to molecular was accompanied by a 50 to 100% surge in reported rates of C. difficile infection. Oh no, said my infection control people. Is that good or bad? Or was it just, oh no, my rates have doubled with my infection control practices in place? So we had lots of discussion at the time when we switched to molecular testing, which was in 2010. Was this good or was this bad? Are we really finding more ill patients? Are we really doing that much better with ill patients? And so that's something to have always kept in mind. At the time that we were surging in our rates and doubling all of our CDI rates, regulatory folks became very concerned. Most states have enacted laws and/or promulgated administrative regulations mandating data submission and public reporting of healthcare-associated infection data. This includes C. difficile rates. They became a measured metric with public reporting and associated monetary fines for high rates above an established benchmark. Because of this, many states have focused their efforts on the occurrence of healthcare-associated Clostridium difficile infections. So it became in your best interest to do the best job possible in detecting only the truly ill C. difficile patients that require antimicrobial therapy. It became in your best interest to prevent the nosocomial spread of C. difficile in your hospital. It became in your best interest to have the lowest rates possible of C. difficile transmission in your hospital. So hospitals became concerned. This wasn't just a laboratory or infectious disease issue any longer, or even just infection control. This became an overall hospital medical center concern. You do not want to over-detect disease? No, because your rates reported to your government agencies will be falsely high. But you do not want to miss an ill patient? Definitely no, because the most important thing always is quality patient care. So problem, complication. No reliable clinical or laboratory definition for disease that accurately distinguishes true disease from non-C. difficile infection-related symptoms in all patients exists. Most diarrhea in patients is not due to C. diff. Symptoms of C. difficile infection are somewhat nonspecific and can occur in patients with other reasons for diarrhea. Asymptomatic colonization is also common. I talked about those people, those silent carriers coming into our institutions. So asymptomatic colonization is also common in many of our hospitalized patients, but they may have diarrhea or other reasons to have their diarrhea, but they're being tested for C. difficile and found to be positive because they're carriers. So the bottom line, the positive predictive value of detecting C. difficile in routine diarrheal samples is quite low. Yes, it's complicated. What do molecular tests actually detect? Well, molecular assays are very sensitive in detecting C. difficile. The sensitivity is in the range of greater than or equal 95%, and they have relatively high specificity. In general, the sensitivities among the available testing platforms are comparable, but the platforms do vary in their ease of use. Detect the conserved regions of toxin A and/or toxin B genes on the padlock of the C. difficile. Because the gene for toxin and not the toxin itself is being detected, and because these assays are so sensitive, there are concerns regarding their use. Differentiation of the carrier state versus active infection and their impact on infection control. Potential for laboratory contamination, particularly with methods that require multiple steps. Changes in test performance over time as new strains emerge. Are those assays still able to detect the C. difficile strain that is circulating in your community? And also, are these tests cost effective? What do EIAs for toxin actually detect? EIAs for C. difficile use monoclonal or polyclonal antibodies directed against C. difficile toxins. Most detect toxins A and B. There are a number of commercially available EIAs for C. difficile toxin detection. They include rapid immunochromatographic, lateral flow membrane immunoassays, microwell, and solid phase assays. The hands-on time required to perform the test varies depending upon the type of test. Their relatively ease of performance. They are usually far less expensive than molecular assays. And the sensitivity for these assays vary widely from approximately 50% to 100% with good specificity. What do EIAs for GDH detect? Well, GDH stands, of course, for glutamate dehydrogenase. It's a metabolic enzyme encoded by GLUD. GDH is produced at high levels in all isolates of C. difficile, including both toxigenic and non-toxigenic strains. GDH of C. difficile is known to cross-react with that of Clostridium sordellii. GDH represents a screening test. Screening tests for C. difficile disease and positive assays must be followed with a confirmatory test, such as a Toxin EIA or molecular test for detection of toxin or toxin genes. Studies suggest that GDH exhibits high sensitivity, somewhat greater than 90%, as a screening test for C. diff infection and exhibits a favorable negative predictive value. But most believe perhaps that PCR assays are generally a bit more sensitive. Excuse me, sir, how did you determine the sensitivity of all of these tests? If you read different literature, like I've tried to do, oh my goodness, there's so many, you can't read them all, but there's different comparative methods used to compare the sensitivities of these tests. So no one would say that all the sensitivity data that we've been given is perfect. There's not been a standard reference method to define C. difficile disease. There have been numerous reference methods that have appeared in the literature for comparisons, such as toxin, antigen, and molecular assays, most commonly compared to either using cell culture cytotoxicity assays or toxigenic stool cultures. So one wonders what really is the true sensitivity and specificity of some of these tests. And my understanding is ASM is actually trying to address this to help us some, because the literature really is quite confusing and complicated. So let's move for the search for the best test. Molecular tests are very sensitive and are increasingly used to diagnose infection, but many molecular test positive patients may lack toxin and only have the gene in the stool. It is unclear if a positive PCR with just the gene in the stool is enough evidence to define infection. Could the PCR positive for the toxin gene just be a colonized patient? Sure could. The EIAs are specific for toxin production and will accurately detect those patients producing high amounts of toxin, but they're not as sensitive as a molecular assay. Could an EIA toxin test miss a significantly ill C. diff infection? And then how does GDH testing fit into the scheme of all of this? So let's go in what at least I have managed to compile are some of the four possible testing options for C. difficile. First off, we've got to have a good stool, liquid or soft stool. From my reading and talking to folks, these seems to be the four possible testing options that most people are headed to these days. You could choose to go with Toxin EIA as a single test. You could do two-step reflex testing in one of two ways. GDH antigen EIA being your initial test, if positive, confirming for active toxin production. Doing a molecular assay as your beginning test, and if positive, do something to look for active toxin. That's what makes up the two-step reflex test. Or you could use molecular testing by itself. Let's talk a little bit more about each of these options. If you choose to go with Toxin EIA for AB as a standalone test, you will find that the well tests in the literature are usually more sensitive than the membranes. When used as a standalone test in a high prevalence setting, the specificity can be poor. In a high endemic setting, the prevalence of around 5%, approximately 20% of patients with a positive test might not actually have C. difficile infection. This could lead to unnecessary treatment. If infection control is a concern, there is not a reliable way to detect carriage of C. difficile if you're using EIA toxin testing as your standalone test. Molecular testing as a standalone. Molecular tests do not detect free toxins. If you're using molecular testing, it would mean you're relying on clinical symptoms for the proper treatment of CDI infections, because you're giving the presence of the gene, not the actual presence of toxin being produced. In my institution, perhaps you have a different way of thinking, but MDs tend to treat a positive result. So if you're sending out molecular testing, chances are you're going to lead to overtreatment. Even though the patient has diarrhea, the patient could be colonized only with C. diff, and the diarrhea could be due to another cause. And remember, there are no specific symptoms to spot a patient with CDI, so you could be treating carriers when you're using molecular testing as standalone. Let's go through one of the reflex test options. This one is using a highly sensitive molecular test, or GDH, enzyme immunoassay, as your primary test. If this is your primary test and the results are negative, on the right-hand side, negative test result, there's no further testing. CDI is unlikely. However, if you have a positive test result on the left-hand side, you have to go to the step 2 of your reflex procedure. This would then be following your highly sensitive molecular or GDH with a highly specific test, such as testing for toxin A and B using enzyme immunoassay. If you then find a positive toxin in that patient, Clostridium difficile infection is very likely. If on your step 2 test it is a negative test result, in your clinical evaluation you're going to have either C. difficile infection or carriage of C. difficile is possible. So that is your first reflex test option. Your second reflex test option is if you're using the GDH and toxin A and B test as a combo test. This is a highly sensitive combination testing. Let's start on the left-hand side. If both these tests are negative, no further testing required. You have eliminated that patient as having C. diff infection. Let's go to the far right-hand side. If both the GDH and toxin A and B are positive, you don't need to do any further testing. C. difficile infection is very likely to be present and you need to treat. There's an optional route if you have using GDH and toxin A and B. This is if your GDH is positive and your toxin A and B is negative. Some experts, such as cited in this article by Dr. Krobosh, has suggested that in instances such as this, you can optionally do a molecular test. If you do the GDH tox A and B negative specimen in a molecular test and it is negative, the CDI is very unlikely. However, if you get a positive molecular test, of course you always evaluate the patient, but you're more likely to have C. difficile infection or carriage of toxigenic C. diff. The reason for the optional center category is this algorithm is to correct for possible sensitivity issues with the toxin portion of the combo test. So if you want possibly ultimate sensitivity, this would be the route that you would take. Medical evidence for the two-step reflex testing. There's a very fine paper by Dr. Pathology at UC Davis that defines a prospective study of thousands of patients tested for C. diff by EIA and PCR. Clinicians had access to the Toxin EIA results only. 55% of the patients positive for PCR were Toxin EIA negative. Toxin negative PCR positive patients had similar disease to those with negative PCR results. There were no C. difficile infection-related complications in the toxin-negative PCR-positive patients. Toxin-negative PCR patients had shorter duration of diarrhea compared to the toxin-positive PCR-positive folks. So this showed that the severely ill C. diff patients were positive for both toxin and PCR. So this helped supply medical evidence that the two-step reflex testing gave better treating information to the physician, better information about whether a patient really had serious C. difficile infection and required therapy. They determined that severe C. diff with negative toxin EIA was really rare. It really was all about the toxin being produced. And this testing approach had been consistent with guidelines also found in the UK. They had adopted this type of philosophy as well, and was also consistent with the 2010 IDSA guidelines. So this gave evidence that the two-step reflex type testing was a very good way to move. Possible questions that come up with this, and I'm sure you will have many, many more questions as well. Why do a PCR or a GDH antigen detection at all if the test result relies on a negative toxin A and B, EIA? Well, it improves your specificity of the EIA results. PCR and antigen tests serve as the broad, sensitive screening test to detect patients negative for C. difficile. If you then follow that with the EIA for toxin A and B to screen the positive PCR or GDH patients, you will detect those that have high levels of toxin. The sensitive screening detects patients potentially colonized, so contact isolation can be instituted, and the PCR, GDH antigen information is still available if a physician has a concern for a falsely negative toxin EIA in a severely ill patient. Some possible take-home points about reflex testing. Reflex testing is being prompted by recent literature that demonstrates molecular tests and GDH antigen have a high negative predictive value, so they're very sensitive, but poor positive predictive value for true infection. Clinical disease outcomes correlate more closely to detection of active toxin. Clinicians get more information with reflex testing. You have active toxin production, which is associated with significant disease, and you have information about colonization that can assist with infection control efforts. Antimicrobial stewardship is benefited. You're only getting therapy of those people who actually have infection, so it's more targeted treatment and will lead to overall less use of antimicrobials. How do you report a two-step reflex test? Well, this is just an example. It's not the end-all. It's kind of the way we decided to go, but I'm sure there are many other good options for reporting. In this example, the primary sensitive screening test is PCR. So a batch of stool specimens are tested by PCR. The not detected negative specimens are immediately reported via the laboratory computer interface to the patient report. The detected or positive PCR results, those specimens are held until the EIA test for toxin is performed. The EIA toxin A and B tests are batched once per day. You could say once per day, isn't that slowing down your results? We discussed this with our clinicians and our infection control people, and they thought that this was adequate. It was all right. After we do the batch testing of the EIA, we report a combo report with both the PCR and EIA toxin A and B result for these PCR positive specimens. So on the left-hand side, we have the possible reports that would be issued from our two-step reflex testing. C. difficile not detected by PCR, and we have an explanatory paragraph saying that this is no C. diff present. C. difficile toxin negative, This means positive PCR, negative for toxin A and B. And C. difficile toxin positive, which means it's positive for PCR and positive EIA for toxins A and B. As I say, you can develop your own reports. This is the way we went about doing it. We also have a narrative that explains our testing within our reports. I don't think I need to read this to you, but we explain what we mean by a C. difficile toxin negative result, and in this result, we tell them that the PCR is actually positive. So we are not withholding information. We are giving them that the C. difficile toxin EIA is negative and that the PCR is positive. In our C. difficile toxin positive result, we are telling them that the toxigenic C. difficile is detected by both PCR and toxin, and then we do a little bit more explanation about what the PCR is actually detecting. As I say, this was our approach, but I'm sure there are many other excellent approaches that people can take. More questions. How can you best implement a reflex two-step testing method? Did physicians readily accept this change in practice and accept those reports that I just discussed? Well, I'll tell you, it was a rather exhaustive campaign to get all of this started, and I think it is very important to have discussion with physician groups most involved with ordering C. diff testing prior to implementation. We went to GI groups, our general medicine groups, infectious disease. We also had some discussions with some of our residents and fellows because they order a lot of the testing and read a lot of the results. We explained what our laboratory test methods were and what we were trying to accomplish by our methods. We explained the goals of stewardship and that really the prime goal of all of this is quality of care. We explained the purpose of the two-step method and the information available in the report. No information is being withheld. If both tests are being run, they are available on the report, and we're saying that it's really more information than they ever had before. But I have to say, every hospital situation is different, but generally this has been positively received. Do stewardship programs really make an impact on C. diff? You bet. Most cases of C. diff arise from a course of antibiotics. A lot of fluoroquinolones are the leading culprit, which can wipe out, of course, the normal flora in the bowel. And this will allow C. diff to flourish and produce the toxins that cause disease. We also know that C. diff infection rates are declining. Hooray, they're declining. One reason is that the NAP1 strain appears to be decreasing. And why? We think it is probably because of major stewardship efforts across the country to decrease the use of quinolones. Most hospitals have established antibiotic stewardship programs to track and control their use, and federal regulations require such programs in nursing homes as well. So we hope that in the future we will be drastically cutting C. diff rates. How do you treat C. diff? Well, it's really ironic that you treat it with antimicrobials, isn't it? But these antibiotics keep C. diff from growing, which in turn treat the diarrhea and complications. As I said before, in the 1980s, we've had metronidazole and we had vancomycin. Well, they're still there, and they're still two of the most widely used agents for treatment. There's a new agent, Difficile, which is also an oral medication approved to treat C. difficile. In one study, it showed that it was a little bit better, possibly, than vancomycin. But one of the major problems with this new oral medication is it is quite expensive, far more expensive than vancomycin or metronidazole. Do probiotics play a role? Oh goodness, we're all into our probiotics, aren't we? And we know that they're bacteria and yeast that can help restore a healthy balance in our intestinal tract. And one might think, well, wouldn't that help? It's all about a healthy balance. You are what you eat. But really, they haven't really proven to be all that helpful in C. difficile. What they primarily say is you can use probiotics as adjunctive for routine treatment of CDAD is not suggested. They really don't think that probiotics plays a role in the general treatment of C. difficile infection at all. But if someone wants to use probiotics, it could be reasonable in recurrent disease as long as it's not that severe. And so there's some data to support actually the Saccharomyces being administered with antimicrobials, and that might help prevent recurrent disease. But I think the story's still out on probiotics, and I'm not sure they're going to prove to be very helpful. What has proven to be helpful? Fecal microbiota transplants, also known as stool transplants or FMT. This has been an alternative strategy for treating C. diff. It's not yet approved by FDA, but it's being very widely used across the country, and it has proven to be very, very effective. It can restore the healthy intestinal bacteria by actually placing another person's donor stool in your colon. It's usually done by a colonoscope or nasogastric type tube. And of course, the donors are screened for medical conditions. Their blood is tested for infections, and stools are carefully screened to make sure that no infections are passed on. And it has a success rate of greater than 90%. So this is really a major step forward, and you just hear stories about how this just changed people's lives after they had these transplants. If you don't want actual poo put into you, there's actually poop in a pill, which you can use. These are becoming more available, and so you can actually do a fecal transplant by ingesting these capsules that contain the right amount of the bacteria that they feel is most important in restoring a healthy bowel. There's monoclonal antibodies that are going to be coming in the market for recurrence. You can get IV infusions of these monoclonal antibodies. They're thought to help with major issues with recurrence, but they're very, very expensive therapies, and time will tell if the monoclonal antibody will take over the stool transplants. And finally, is there a vaccine on the horizon? Well, there may soon be some vaccines. They're in phase 3 and phase 2 studies right now. So in the near future, we might actually have some C. difficile vaccines. And yes, it is complicated. I hope that this has given you a brief review of the considerable knowledge that we've gained over the last 30 years. We've seen C. diff emerge as a major pathogen and a nosocomial menace. Controversy surrounds laboratory testing to this day, and the creation of the two-step reflex testing is just one possible strategy. What was old is now new again with the use of EIAs for toxin A and B. Antibiotic stewardship and infection control efforts halt the spread. There's improving therapies, and we added fecal transplants into monoclonal antibodies to the possible vaccines being developed. And finally, I thank Angus and Barney. They are being trained to sniff out where all the rest of us have feared to go. They are actually being trained to go into hospital wards to sniff and detect C. difficile. And who knew? They're as sensitive as some of our laboratory tests, and they are very cost effective. So I bow to you, Angus and Barney. Perhaps you're the future in the laboratory and my next employees. And with that, I close, and I will gladly accept any questions or comments, and I would love to hear what some of you have to say about what you're doing. I thank you very much for being able to share some time with you.
Thank you, Dr. Morgan, for a very educational and informative presentation. It was great. Thank you so much. It is now time for our question and answer session. If you would like a question answered, please feel free to click the Q&A button on the lower left-hand corner of your screen. Type your question in the open area and click Ask to Submit. So our first question, we are currently trying to reinstitute EIA GDH testing at our facility. A lot of Orange County hospitals are using PCR testing in addition if the test comes back antigen positive and toxin negative. What would be the theory behind using PCR testing for this algorithm? Would not PCR testing still catch colonized patients?
Well, some people would say that that would be an advantage to still detect colonized patients. We have a major infection control effort at Cedars, so we are actually isolating the colonized as well as those that have active C. difficile infection. So I think it really depends on what your objectives are. If you want to know who's colonized or not, and if you do not want to know who's colonized, and you're using PCR, you then need to look very carefully at the patient to assess how seriously ill they are. And a lot of people are using molecular tests by themselves even, and just very closely looking at the patient and making decisions about whether treatment is warranted or not. Does that answer what they wanted to know? I hope.
I think so. Our next question, since infection control is the keeper of the kingdom, and NHSN, National Health Surveillance Network, defines an HAI as lab detection of either toxin gene positive or toxin EIA positive, could you make a recommendation based on what your institution is doing?
Okay, can I just one second. Is there some way I can see these questions? I'm sorry, 1 second. I'm just trying to see if I can actually view the question. I'll be able to respond a little bit better. One moment. I can't always pick up what you say. Okay. Okay, so what we're doing, okay, we're using molecular detection to detect our carriers because of infection control, and because we want to make sure that we're isolating all patients that should be isolated. But we are using the toxin antibody test to define who is actually ill and needs therapy. I don't mean that to be a roundabout, elusive way to answer that question, but we consider our toxin A and B positive patients are patients who are truly ill and need treatment.
Thank you, Dr. Morgan. Next question, what would cause a GDH negative and toxin AB positive on the screening test? I do not have a lot of experience with the GDH test. There is lack of specificity in the toxin A and B assay, and I think that's what you're picking up from having a GDH. The GDH screen certainly is not 100%. It's probably in the high 90s, however. So if you have a GDH negative toxin A and B, I would think that you most likely have a non-specific false positive reaction in your toxin A and B. We've seen some of this in IBD patients and in people with Crohn's. They have some false lack of specificity in some of the enzyme immunoassays. Okay, thank you, Dr. Morgan. Next question, how about reimbursement? Do most insurances pay for both the PCR and EIA?
Oh, I knew that question was going to come up, and I didn't want it to. I have no clue. You know, you have to look at your own institution and how reimbursement goes. We are a very complex tertiary care institution at Cedars. A lot of patients are falling under DRGs, and we do offer it as a battery, a test battery. And we do issue a billing request. I do not have data to say how that is being reimbursed. I'm sorry, I do not.
That's okay, Dr. Morgan. Thank you. Question?
But I know that as time moves forward, of course, reimbursement will be an issue for all of us. We do have so few toxins done. The EIA toxin A and B is done in comparison to the numbers of PCR assays run, that our primary billing test is PCR. But we are looking, but we're developing a battery to bill the EIA test. But as of right now, our primary billable test is PCR because that is by far our screening test.
Thank you, Dr. Morgan. We will have time for just a couple more questions. I wanted to let the audience know we will email responses to all of your questions following the webinar. The next question we can take, do you do the toxin testing confirmation for both inpatients and outpatients? If done on outpatients, is billing allowed for both tests? So a similar question, we can answer you privately.
We would just bill for the PCR on the outpatient, and yes, we thought it was easiest for our laboratory, and many of our outpatient physicians are also inpatient physicians at Cedars, and we thought there would be less confusion if we did uniform testing across the board. That was our own decision at Cedars. It would not, I don't necessarily say that would be everyone's decision, but that worked best for us.
Thank you, Dr. Morgan. Last question, how do you report lab ID events in NHSN for CMS? If the molecular test is positive, but the toxin test is negative, does it still get reported as a lab ID C. diff, or only if both tests are positive?
Yes, we consider the PCR test as our screening test, and our test reportable for reportable infection and treatment is the toxin A and B. So that is what we are reporting. We do not want physicians to necessarily take action on the PCR positive, toxin negative patients. We are doing this to assist our infection control practitioners.
Thank you so much, Dr. Morgan. Like I said, we will email responses to all of the questions that were submitted today. We thank the audience for their engagement and all of their questions.
And I thank you all. Thank you for listening.
Thank you. We hope you found this webcast very educational and informative. This concludes our webcast, and you may now disconnect and have a wonderful day.